Welcome, everyone. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston and I'd like to welcome you to today's GlomCon seminar. Today, our talk is titled Evolution of the KDIGO Guidelines. We have two speakers, and then we'll have a discussion at the end. Our speakers today are Dr. Brad Rovin. He is professor of nephrology at The Ohio State University Wexner Medical Center and director of the Center for Clinical Research Management. And our second speaker is Dr. Sayna Norouzi. She is an associate professor at Loma University Medical Center and the director of the Glomerular Disease and Polycystic Kidney Disease Clinic, as well as the director of the GlomCon Glomerular Disease Fellowship Program. So with that, I am going to turn it over to Dr. Rovin to
Okay.
begin.
Thanks so much, Dia, and welcome everyone. It's nice to be here. And why don't we go to the next slide? So the objective of my talk today is to give you an idea of how we evolved the 2025 IgAN treatment algorithm, which I'll just say is a work in progress, and we'll talk a little bit about how it may be updated going forward. Okay. Dia, are you doing it? Okay. These are my disclosures. I work with a lot of companies who develop IgA therapeutics, but I hope you'll find this unbiased. Next, please. Okay, so as you all know, this is the main diagram from the 2025 KDIGO guidelines that were published in the fall. And as you can see here, we sort of took a new approach to thinking about treatment of management of IgA nephropathy. And at the very top, we had IgA nephropathy at risk of progressive kidney functional loss, and we'll talk about that in a little bit more detail. And then we talk about managing the specific drivers of IgAN nephron loss, and then simultaneously managing the generic responses to IgAN-induced nephron loss. And so that's something that's different, and I think it's different because we finally have some therapeutics that actually can address some of these issues, at least theoretically. And in fact, we know that these drugs are showing benefit in clinical trials. Okay, next slide, please. So let's talk about what is IgAN at risk of progressive kidney functional loss first. Next, please. So we have defined this here as patients who have proteinuria of, oops, one back, Dia. Yeah.
Brad,
Uh,
I'm gonna give you remote control.
oh, okay. Click.
What? I don't know. Never mind. Sorry, it won't let me do it, but I was gonna try. I apologize for interrupting.
Oh, okay.
Okay.
Okay. So that's okay.
It just
Uh,
keeps, I'm moving back. There we go. Okay.
Okay. So anyway, in the guideline, we talk about um, in the guideline we talk about thinking about patients who have progressive loss of kidney function as having a proteinuria of 500 milligrams a day or the equivalent, while on and off the treatment for IgA nephropathy, and we should consider treating all of these patients. And that's a little bit different than we've done in the past, where we talked about progressive IgA being more in the realm of greater than a gram of proteinuria a day. And then in terms of defining the treatment goal in patients with IgA nephropathy and progressive loss of kidney function, we actually talk about a treatment goal of reducing the loss of GFR to what would be considered physiologic in most people over the age of 40, so 1 mil per minute per 1.73 meters squared per year for most adults, and to get proteinuria to 500 milligrams a day or less, really as low as you can go safely. And this caused a lot of consternation in the community because this is not traditionally what we've done. Next slide, please. So I think very much in line with this is that the radar study from the UK folks in the UK Biobank really reshaped or started to reshape our thinking about IgA nephropathy. I think most of the audience is probably familiar with this paper. It's quite good. And on the left, they show a decline in or survival from kidney failure or death, depending on what the proteinuria is. And what I've pointed out is that in patients with very low proteinuria, so in other words, between 500 milligrams and a gram, you can still see that 30% of these patients progress to kidney failure or death within 10 years. And then on the top, I have a little red arrow, 20% in the range of under 500 milligrams. And so that really caught everyone's attention and was a little bit surprising. And then the heat map on the right is really a calculation of given the length of time, since most of these are young patients with IgA nephropathy, and the rate of decline of kidney function, where we have to be for most of these patients to maintain kidney function throughout their lifetime without needing kidney replacement therapy. And I can't summarize the chart in detail, but you can see it in the paper. But the conclusion is to get the GFR decline to less than 1. So when we did this, it was sort of criticized to some extent because this was really only found at that point or published in the radar cohort from the UK. And they said, well, maybe this is a one-off. This isn't our experience, et cetera, et cetera. Next, please. And so one of the things we'll talk about in the new guidelines, next, please, is that there's actually a lot more data coming out now that support the idea that IgA nephropathy is not a slow-moving benign disease. IgA nephropathy can progress with very little proteinuria, and it should, in patients who have a long-term exposure to the disease because they're young when they start, really should give consideration to earlier action. This is the outline of a cohort from Southern California. This was through Kaiser, Southern California. They looked at a huge number of patients. They had about 1,000 patients, close to 1,000, with confirmed IgA. And then they studied in this cohort adults with primary IgA of about 655. The primary outcome in their study was a 50% decline in GFR, kidney failure, or mortality. If you go to the next slide, okay, so you can look either at the left of baseline proteinuria or time-averaged proteinuria over follow-up time in years that they had data on these patients. And what you see is that in both graphs, either baseline proteinuria or time-averaged proteinuria, if you are having a proteinuria between 500 milligrams and a gram per day, or UPCR 1 gram per gram, you can see that a not small percentage of patients actually meet the endpoint of a decline in kidney function, renal failure, or death. And this is not only in now a UK population and a Southern California population. Next slide, please. We have cohorts from Sweden and China. Again, I've put the arrows at what we had thought was sort of a safe range, 500 milligrams to a gram of proteinuria, and you can see that you do lose GFR in the Swedish cohort, and you do lose GFR in these folks in the Chinese cohort. And so we're having more and more confidence that early treatment and lower proteinuria targets, both to start treatment and as a goal, are appropriate in patients with IgA nephropathy. Next, please. Okay, so now we have IgA nephropathy, and we suggest early diagnosis and consider biopsying patients if their proteinuria is 500 milligrams or more. We usually want to start with adding a RAS inhibitor. All of the trials to date have used a RAS inhibitor. Whether or not we need to do that in the future, another point of discussion we can talk about. But then consider adding on to that a treatment with a novel therapeutic agent. And of course, the treat to goal would be a UPCR less than 5, or as low as you can safely go, and treat to achieve a GFR slope less than 1 mil per minute per year. And of course, it's really clear that you cannot understand the GFR slope, unfortunately, sort of a priori as you're treating the patient, because you have to have time and look at GFR slope over months to years. But we can look at a proteinuria goal. Next, please. So how do we get there? Next. Okay, next, please. So what I want to do is is sort of now give the rationale of how we came up with the scheme. And the scheme of management is based on our current forehead hypothesis of the pathogenesis of IgA nephropathy. And I think you've all seen this diagram probably a million times lately because everyone's using it or something similar. But we know that from the mucosal surfaces, gut, respiratory tract, we can get an abundance of galactose deficient IgA. We think that some galactose deficient IgA may be pathogenic, maybe not all of them. And of course, we cannot measure clinically galactose deficient IgA yet, so making these correlations is quite difficult. So HIT1 is elevated circulatory galactose IgA in the circulation, and then HIT2 is production of IgG autoantibodies or antibodies. Some people argue they're not autoantibodies, but antibodies to the galactose deficient IgA, formation of immune complexes as HIT3, and then HIT4, you have deposition in the glomerular mesangium and the ensuing activation of inflammatory processes and profibrotic processes cause HIT4, which is damage to the kidney. Now, next slide. Okay, so what I'm showing you here is when the KDIGO guidelines were being updated at the time they were published, we only had the drugs in blue, which were Nefecon, systemic steroids, mycophenolate. We had an approval of a dual endothelin angiotensin receptor antagonist and SGLT2 inhibitors. However, we do know that drugs in red, based on what their mechanism of action should be, it's not too hard to figure out where they belong in this scheme. And of course, if you look at the B cell modulators, and now we have an approved B cell modulator, at least accelerated approval, we do expect that to interfere with production of the antibodies, IgG and IgA. And by interfering with the production of the antibodies, they're going to interfere with immune complex formation. And we know that we now have a complement inhibitor approved, and the complement inhibitor is expected to at least mitigate some of the complement activation at the level of the kidney from the deposition of the immune deposits, immune complexes, immune aggregates, whatever you would like to call them. Next, please. So now if you relook at the guideline and then combine it with the four-hit hypothesis, hit next now, and an animation will ensue. Hit again, another animation, hit again. Okay, so when you look at this, what we're really saying is when we manage the IgAN-specific drivers of nephron loss, we really have hits 1, 2, and 3 when we've sort of combined them based on what the drugs that we have at hand do. And then we have hit 4, which is, of course, the consequences in the kidney. Hit 4 isn't purely sort of within the IgAN specific drivers of nephron loss, because as you lose nephrons, of course, you get hyperfiltration and injury in that manner. So HIT4 and CKD management sort of go together as well. And so I think this makes this diagram maybe a little bit more palatable for folks to understand where we're coming from. And of course, when you go down the diagram, at the time we had put out this KDIGO guideline, even though 2 drugs were approved prior to the publication of the guideline, iptacopan and atrasentan, we hadn't had time at that point to go over the data because they were not available while this guideline was being worked on. And so what you see here for hits 1, 2, and 3 were Nefcon, because we assumed Nefcon is acting at the production level of the galactose deficient IgA, theoretically based on its mechanism of action. And we also had systemic steroids, and systemic steroids are anti-inflammatory, and we understand that they probably work at the level of HIT4 or kidney inflammation. Now, of course, we have much more information. So let's go to the next slide, please. So one of the things that we also sort of advocated was should we be talking about single therapies or combination therapies? And I'll just show you what the effect of the approved therapies on proteinuria at 9 months look like. And what you see here is all of the drugs now that have been approved. And you can see what their baseline proteinuria of the group is and what the post-treatment proteinuria at 9 months is. And you can see that very few of these really get down to the level of under 500 milligrams. In fact, none of them do. On the other hand, what you see is some get close. But this really suggested to us at the time that combinations of therapies may be necessary to achieve a low level of proteinuria, not for everybody, but for many patients. Next slide, please. If you similarly look at the effect of approved therapies on GFR loss, where we actually have data, you can see that the drugs listed, sparsentan, Nefecon, methylprednisolone, and SGLT2 inhibitors, we have a treatment arm decline that is not necessarily approaching the -1 ml per minute per meter squared or better. Okay, so again, this suggested to us that we might need to have combinations of therapy to achieve that very low level of GFR decline. And of course, this will remain to be seen as we see the other drugs coming down the pike with their GFR data, which is necessary for approval at this point. Next slide, please. Okay, so the effect of the approved therapies on galactose-deficient IgA, at the time we published the guidelines, all we had were data on Nefecon, and what you see here are the changes in IgA over galactose-deficient IgA circulating over time in the patients treated with Nefecon, and of course the treatment in the trial stopped at 9 months, and then the galactose-deficient IgA recovered by about 12 months or a little bit after. Next click, please. And so since that period of time, we now have data from the testing trial. And one of the controversies was, well, do systemic steroids, systemic glucocorticoids actually decrease galactose-deficient IgA? And there was not a lot of positive data out there. And so we had drawn the diagram suggesting that systemic steroids more affect the inflammation in the glomerulus as opposed to the sort of the hits 1, 2, and 3, the galactose-deficient IgA and the initiation of IgA nephropathy. But we now know that, at least in the cohort from the testing trial, the patients did drop their galactose-deficient IgA. And not unexpectedly, I would say, there was a decline with systemic glucocorticoids. And we know as well from the recently published trial on sibeprenlimab that there's very large changes in serum galactose-deficient IgA. Okay, next slide, please. Okay, so now when you think about the guidelines as published, this is where we were. And the way I've sort of see myself modifying this is that we want to stop the synthesis of pathogenic IgA forms and then stop the immune complex, immune aggregated deposits in the kidney from injuring the kidney. So do another click, please. And, I've been asked many times, why would we do both of these things, manage the damage at the same time as well as the immunology? And I would have to say, more than anything else, it's a philosophy. So the philosophy is, why would you not treat an immunologic disease immunologically if you had safe drugs to do so? And I understand that's sort of pie in the sky when you think about it, right? You all want evidence for it. And I think there may actually start to be some evidence for that. Next slide, please. Next. Okay, so this is data that we presented at the ASN, and we're currently writing this up, but this is a post-hoc analysis of the NefIgArd trial data looking at eGFR after reaching a proteinuria less than 1 or less than 0.5 at 12 months. And you can look at either one of the graphs, but you see a decline in GFR. Let's look at graph A, and the yellow line is the stabilization of the GFR over at graph A. Dia, put the little arrow over by graph A. Yeah, the very top line is NEFCON. Okay, and that's its decline. And then if you look at the placebo getting the proteinuria down, which is the blue line, you can see that it doesn't do as well as the Nefecon treated patients getting the proteinuria to the same level. So let me explain this a little bit better. These data, my interpretation of these data suggest that it really does matter how you get the proteinuria to go down. So if you get the proteinuria to go down simply using RAS inhibition to the same level as using RAS inhibition plus an immunologic agent, in this case, Nefecon, you actually do better in terms of GFR preservation with the immunologic agent. So this is a really important concept. And what I hope to do is, as we see the other immunologic agents come on board, we can do the same sort of analyses of these trials to see if this concept bears out. Because that's the big argument, which is, well, if you already could get proteinuria down to something good with a RAS inhibitor, why bother using anything else? And the why bother using anything else suggests that if you treat the disease to its immunology, you might have bigger benefit in kidney preservation. Last slide, please. Okay, so the 2025 KDIGO guidelines, they're already due for an update because things are changing so quickly. I think we're going to leave IgAN at risk for progressive kidney functional loss right at the top, and we're going to continue to urge, given all the new cohort studies and data, that we do really want to attack this disease early. We're going to, again, talk about the management of the pathogenesis of IgA nephropathy on the left and the management of chronic kidney disease on the right, and those should be done at the same time. One of the unfortunate things is, at least in the United States, by the time we see our IgA patients, most of them already do have chronic kidney disease. In other countries where there may be screening and patients are seen earlier, the right side may be a little bit less relevant right from the beginning, but eventually it probably will be. And so I would suggest that then we go down this algorithm. We want to manage hits 1 through 3, and we can manage hits 1 through 3 with sibeprenlimab, Nefecon, and I would dare to say also systemic glucocorticoids because they do decrease galactose-deficient IgA. And then I put in red the BAFF/APRIL inhibitors. Those data will be forthcoming very shortly, but you've seen some of the phase 3 trials presented at the ASN, and you know that they worked very well in decreasing galactose-deficient IgA and should manage hits 1 through 3. And then, of course, managing hit 4, we're looking at the systemic glucocorticoids. We talked about inflammation, and we can also add on sparsentan and atrasentan to manage the hemodynamic and sort of vascular effects of the IgA deposits, iptacopan, or complement inhibitors to manage complement activation, and of course, RAS inhibition. On the right side of the diagram, we want to manage chronic kidney disease. Obviously, we want to control blood pressure. We want to reduce glomerular hyperfiltration, and we want to always keep an eye on cardiovascular risk reduction in any of our patients with chronic kidney disease. And so we've maintained lifestyle modification, RAS inhibition, SGLT2 inhibition, of course. I included sparsentan and atrasentan on this side too, because I think they do a really good job of lowering glomerular filtration pressure, hyperfiltration. And so that's sort of how it's a little bit murky that there's a real separate distinction between hit 4 and chronic kidney disease, but certainly hit 4 is on the pathway to chronic kidney disease. And so I'm going to stop now and we'll have time to discuss this. And I think Dr. Norouzi is going to take over. Thank you.
Thank you, Dr. Rovin. And yes, we're going to move on to some cases. And then, as I said, we'll have a discussion at the end. So now I'd like to welcome Dr. Norouzi.
Well, thank you so much. Thank you, Dr. Rovin. That was a fantastic talk. I'm going to go over a case, and after that, we're going to have a discussion and we can take questions. Thank you, GlomCon, for having me here, and thank you, our sponsor, for inviting me today. I'm going to present a case. We can go to the next slide. This is a 43-year-old Hispanic male. He had biopsy-proven IgA nephropathy. The biopsy was done 3 years ago. He has history of CKD stage 3B. I was diagnosed 5 years ago, and he's progressing to kidney disease stage 4. He has history of hypertension. It's a long-standing hypertension, but it's really well controlled at the time that he came to the clinic. He's been taking benazepril 40 milligram daily, and he's been on the maximally tolerated dose for himself. His blood pressure is well controlled, and he's been taking this medication for 5 years. At this time, his eGFR is 29, his urine protein to creatinine ratio is 1.1 gram, and his creatinine is 2.8. Next slide. So we did a kidney biopsy, and I really like this slides because it shows exactly what we see on the biopsy for this patient. It was a good sample, about 20 to 25% IFTA on the biopsy. As you see, we see some mesangial hypercellularity. There is no endocapillary hypercellularity for the patient, and we don't see any crescents. We do see some segmental sclerosis that is not surprising in this situation. And again, as you see there, arrow is actually showing us exactly what we are talking about. These are the sclerotic lesions that we see on the biopsy for this patient. And IF showed IgA, obviously. So this patient is being diagnosed with IgA nephropathy. It's a biopsy-proven IgA nephropathy. IF actually showed some staining for C3 as well. Just keep in mind when we are thinking about it, and I know that we get a lot of questions about the findings of the biopsy findings for patients with IgA nephropathy. Next one. And this is the EM. As you see, we see the mesangial deposits on the biopsy. And it's really beautiful. I think like when you see these arrows and it actually shows what we are talking about, the deposits on this patient. So it's obviously here that you see all these deposits all over the biopsy. And well, the patient had the diagnosis of IgA nephropathy, and we do have the report. Next slide. Again, more mesangial deposits, normal GBMs, and we had some food process effacement as well. So the report came back as IgA nephropathy with segmental sclerosis. His MESI score is M1, E0, S1, T0, C0. And there are no features of lupus nephritis. We do have some mild arterial nephrosclerosis. And I know that number 3 is just like a minute portion of renal cortical neoplasm that was not significant, clinically significant in this situation. So we just had a fantastic talk by Dr. Rovin on IgA nephropathy and how the landscape is evolving. I'm gonna say that once this patient is in our clinic, as we are following up on the KDIGO guidelines, we want to make sure that we are dealing with primary IgA nephropathy. So as the first step, we're gonna rule out the other causes of IgA nephropathy. For example, if it's, first of all, we want to make sure that this is not IgA vasculitis. It wasn't the case for this patient. We rule out viral infection, HIV, hepatitis. We always ask the patient about IBS and IBD, other autoimmune diseases. And obviously, if the patient is cirrhotic, that's a different story about seeing IgA on the IF. And again, we don't want to deal with IgA dominant infection-related GN if we are actually aiming for the newly FDA-approved medications. Again, for all the clinical trials, these causes of IgA nephropathy as the secondary causes, they were excluded as well. So once you exclude all of these causes, then we know that we are dealing with idiopathic IgA nephropathy or primary IgA nephropathy. Then we do have the MESI score for this patient. We really want to actually quantify the progression risk at the diagnosis at this time. And again, a lot of that goes back to the physician and nephrologist who's treating the patient and your opinion about if the patient is considered high risk for ending up on dialysis or transplant. Always, it's recommended per KDIGO guidelines to include these patients in the disease registry as as well. This is a rare disease where we want to follow up on these patients, especially now we have newer options and we want to see how patients are going to react and how they're going to respond to the new medications. And again, changes in lifestyle, cardiovascular risk management, weight loss, changes in their diet, etc. So these are the initial consultations that we provide to our patients. So I don't know how many of you use actually the calculator right now. I usually use that when I have a training in the clinic. So we know that the calculator can give us some information about the prognosis of IgA nephropathy. With having newer medications and changing the landscape of IgA nephropathy, a lot of patients that we see in the clinic right now, they might have failed treatment in the past, or they are on a treatment that is one of the newly FDA-approved medications, but they're not responding the way that you want to see after a couple of months of being on the medication. They come in for a second opinion. So it's time to have a new calculator for IgA nephropathy. But so far, what we have on this calculator basically is including the amount of protein in the urine at the time of biopsy, blood pressure for the patient, eGFR at the time of biopsy. We include race, MIS-C score, and use of ACE inhibitor or ARB at the time of biopsy. So I usually, when I have fellows and residents, they calculate the risk for the patients to just have some understanding of what's going on with the patient. Next slide. So looking at the newly approved, basically the KDIGO guidelines, as we talked, and now we do have other agents as well, but this is the published version of KDIGO that we have, and it's available to community nephrologists and all the nephrologists at this point. So if we want to follow up the KDIGO guidelines at this time, I consider this patient as high risk for progressive kidney function loss. Obviously, this patient is progressing to CKD stage 4, has lost a huge portion of his kidney function. His proteinuria is on a higher level. Actually, this patient had hematuria on and off as well. A question that comes up usually in clinic, what about hematuria? And this patient did have hematuria. And I do urine microscopy on all of my suspicious patients, like all GM patients, but especially for IgA nephropathy. And he does have dysmorphic RBCs on and off as well. So if we want to go down on the KDIGO guidelines algorithm, then first of all, we want to manage the generic responses to IgA nephropathy-induced nephron loss. And then we want to basically manage the cardiovascular risk as well. Cardiovascular risk reduction is really important for IgAN patients. We do have data out there that these patients are at higher risk of cardiovascular events. And this is something that I do not want to forget about it, especially now we have newly FDA-approved medications focused on the autoimmune part of the disease, but we have to make sure that we are addressing the cardiovascular risks as well. So for the CKD care, obviously, we want to manage the blood pressure. For the patients, this patient blood pressure is optimally managed. For the reduced glomerular hyperfiltration, proteinuria, and the impact of proteinuria on the tubules, we want to basically talk about lifestyle modifications. Patient is already on RAS inhibitor, but then we are talking about the dual endothelin inhibitors. You can always change that to a medication, dual endothelin inhibitor as sparsentan, and now we do have atrasentan as an add-on as well, plus minus SGLT2 inhibitors. I saw some questions about SGLT2 inhibitors on the chat. That it's my practice that I actually have my patients with IgA nephropathy on SGLT2 inhibitors as well. And then we're going to think about managing the IgAN-specific drivers of the nephron loss at the same time. So we do not wait for 3 months anymore, and we want to address the autoimmune, and then we want to go after the 4-hit hypothesis that we believe in the setting of IgA nephropathy. So we want to actually decrease the production of pathogenic forms of IgA and IgA immune complexes, and we want to stop the IgA immune complex mediated kidney injury. So on the KDIGO guidelines, we do have Nefecon/systemic glucocorticoids. Systemic glucocorticoids, it's not part of my practice at this point, as I think that we do have better FDA-approved medications with less side effects. At this point, of course, we need long-term data, but systemic glucocorticoids in general causes a lot of side effects in long term, and we are dealing with a disease that a lot of my patients come back with flares, and they've been dealing with the disease for long term. Cellcept or mycophenolate mofetil is a medication that historically had been used in the US as well. I do get a lot of second opinions on patients that they received mycophenolate mofetil for a long time, and they come in even with a flare. or sometimes their disease is well controlled and they want to know if they have to switch with something else because they've been on mycophenolate for a really long time. We do have the data from mycophenolate from only China. So it's only being studied in a clinical trial for the Chinese population. So we do not have the data, and that's the reason that you see that on the KDIGO guidelines. If you want to be data-driven, then we don't have data on other races. Hydroxychloroquine, the same thing. We do have data from Chinese population. And tonsillectomy, we do have a lot of data from Japanese population. And again, that's not part of the practice in the US, although I've been hearing here and there, but it's not data-driven, and we don't have any clinical trials or data for population in the US. And always consider the option of a clinical trial. This question comes up, how do you enroll for a clinical trial when you do have FDA-approved medications? That's a really valid and good question, but we haven't found a cure. And if you're not enrolling for clinical trials, we're not going to have more options for our patients. There are so many reasons that patients might actually choose to go into a clinical trial before trying any other medications, and always consider that as an option for your patients. So I think it's really, we always focus on the options that we have for the patients, but there is this really nice table on KDIGO that what are the agents that are not recommended? And we do get a lot of questions about these agents as well. So azathioprine is not recommended. And you might say that no one uses that, but I actually see patients on azathioprine, and especially for female patients, because someone at some point thought what if the patient gets pregnant? So I'm going to use a pregnancy kind of safer medication for this patient in case she gets pregnant, although they're not planning to get pregnant, or it hasn't been discussed with the physician. So I do get patients on azathioprine sometimes. Cyclophosphamide is not recommended unless in the setting of rapidly progressive IgA nephropathy. And as nephrologists, we all know that if you are dealing with RPGN, that's a different setting. And usually these patients are in the hospital. And at that point, then you're going to talk about cyclophosphamide. Otherwise, it's not recommended in outpatient practice for patients with IgA nephropathy. Calcineurin inhibitors, it's not recommended. We don't have any evidence of efficacy for these patients for CNIs. Again, we do see that sometimes in practice, but we do have better medications at this point for IgA nephropathy that is proven by clinical trials, and a lot of focus on long-term data for these patients on these newer medications. At the same time, we don't have data on CNIs. Rituximab, the same thing. Fish oil comes up all the time about what about fish oil? Should I take fish oil in addition to other medications? Do you think it's going to help because it's not going to hurt me? And patients who wish to take fish oil should be advised about the dose, that it's going to be really high dose. And again, it's not recommended per KDIGO guidelines. It's a medication that patients can get over the counter. I don't know how much you can tolerate high dose fish oil. It's going to be really hard. And there are really big actually capsules. And again, it always comes up. Should I add it on? And if I can tolerate, is that okay? It's okay to take it, but I don't have any data, and it's not recommended per KDIGO guidelines. So there is this section about the management of IgAN-specific drivers of nephron loss. And at the time that KDIGO was published, we didn't have enough data on Nefecon. And there is this recommendation actually from KDIGO guidelines. It's not a practice point, it's a recommendation that we suggest treatment with 9 months course of Nefecon for patients who are at high risk for progressive kidney function loss in the setting of IgA nephropathy. And it's a 2B recommendation. And then on the practice point, there are some factors to consider before using Nefecon in patients with IgA nephropathy. First of all, a 9 months course of treatment for Nefecon, a targeted release formulation of budesonide, may not result in a sustained clinical response in terms of proteinuria reduction or eGFR stabilization. It brings out the point that in real life, you might need to consider another course of Nefecon, or sometimes you might consider a longer-term treatment with Nefecon, or if you have other agents, like if you're thinking about combination therapy. Again, it's on KDIGO guidelines, and you need to, it's a practice point, but it's really important that KDIGO is actually acknowledging that we have the paucity of data, and it's good to know that, because as you're using it in practice, keeping it in mind that you might need to adjust how long and how much of the medication you're going to use for your patients. Data on the safety and efficacy of additional courses of Nefecon are awaited. There is an extension study ongoing for Nefecon right now, and I think it's a really important study, and it's really important to have more data on long-term use of these medications and also second course of Nefecon when it's needed for patients, and see how they're going to respond if they get another course of Nefecon. Nefecon's approval status and available, it's available it's very globally, so it depends on where you practice, which country you're at, and if you don't have access to Nefecon, KDIGO had mentioned systemic corticosteroids as well, and I think that's the point, that KDIGO wants to remain international, and if you don't have access to newly FDA-approved medication, there is some guidance how to treat IgA nephropathy. Next slide. So how I managed this patient, patient was already on benazepril at the time that he came in, and his blood pressure was really well controlled. At the time that I was seeing this patient, I only had access to Nefecon, so we actually discussed Nefecon, and I know that the data on lower eGFR levels is kind of, we don't have a lot of data. Unfortunately, a lot of these patients with lower eGFR, pregnant patients, post-transplant patients, they usually get excluded from the trials, and the data is not out there. However, we did have this new medication available, and I was able to get it for the patient. After hearing about the possible side effects of Nefecon, patients said that I definitely want to try Nefecon at this point, and I'm not ready to go on dialysis. I'm not ready to talk about not like working, etc. He's really young, providing for his family. So we started Nefecon. We started SGLT2 inhibitors as well. The question is going to come up, why are you starting SGLT2 inhibitors later than Nefecon? I ordered both at the same time. Interestingly, it got approved from the insurance like later, after patient started Nefecon later on. So as you see, the proteinuria came down and eGFR kind of stabilized. It's really interesting. As you see, it's a single case, but my case actually followed the NefIgArd trend that you see in the setting of eGFR and proteinuria as well. So you do see some increase in the eGFR as you start Nefecon, the same that you see as in the NefIgArd trial as well. It kind of took about 3 months to see a good response to Nefecon and reduction of proteinuria. That is aligned with the NefIgArd trial data as well, that we did see that we need to wait at least 3 to 4 months to see some response as well. This is a patient that received Nefecon for longer than 9 months, and his eGFR was stable. He was tolerating the medication really well. He actually didn't have any side effects with Nefecon. Interestingly, his blood pressure actually remained stable. I didn't make any changes. At this point that I have access to other medications, we actually have talked to him about adding atrasentan to benazepril at this point, or maybe you can always consider switching benazepril to sparsentan as well. So that would be something that I would consider for this patient. We do have other options at this point, and you might ask me, would you consider SIBE or would you consider eptacopan for this patient? Obviously, those options are reasonable if you want to consider those options for the patient as well. Since the patient responded really well to Nefecon and was tolerating it really well, we continued, and we recently tapered down Nefecon for him. With the data out there, I might see a flare on him, but he's been stable so far. So that's the story of the patient, and I think this is my last slide. So we are here to answer your questions.
Thank you, Dr. Norouzi, for sharing the patient case with us. We do have some questions in the chat, and also if anyone has any questions they'd like to ask directly, please raise your hand and we'll allow you to unmute as well. So I think, we'll start with a couple of things that have come up about, since we're fresh on this case. One question is about repeating the kidney biopsy, and when do you consider that, particularly in IgA? And both you and Dr. Rovin can comment, especially since as we have not only newer drugs being approved, but also we presented some data on repeating a course of Nefecon with a response. How does the biopsy play into your practice?
I can go first. So actually for this patient, I'm not planning to repeat the biopsy because he's stable. His proteinuria is well controlled. His eGFR is stable as well. And this is what patient wanted, like, eGFR stabilization. So as long as he's stable, I wouldn't repeat his biopsy. Given that if he comes back with a flare, with proteinuria, hematuria, I don't think that at that point I'm going to need to repeat the biopsy for this patient as well. However, I'm a fan of repeat biopsy at the time that I need some guidance for changing the treatment. For example, there are some patients that might be on, actually, I do have some patients on newly FDA-approved medications that they're not responding to it, and they continue having sometimes even worsening of proteinuria, which is really interesting. At that point, I think a repeat biopsy can guide the treatment and see if we are missing out on anything. For post-transplant patients, I'm a fan of using, we don't have a lot of data, but I do have patients on newly FDA-approved medications as well. At the time that we want to stop the medication, I actually repeated the biopsy for a couple of my patients, and I really want to actually publish those data that I think that it's really important to see what you're expecting from the repeat biopsy and how it can help you to guide the treatment if you're planning to taper down in what do you want to see, because it's different story than C3G, and you might still see some IgA on the biopsy, and how it's going to guide us for changing the treatment. That's a question that we need more data on it, but I think it can help us when you are trying to change the treatment course, or if the patient is not responding to the treatment well. I give the floor to Dr. Rovin. You're on mute, Dr.
Okay, I'm not muted anymore. Yeah, I think you said it very nicely. I think that the data on how the biopsy helps us has not been particularly robust because none of the trials really had coincident biopsies where we actually knew what we were treating in real time. And I think a lot of the drugs are now being tested in smaller rebiopsy trials to see if we can find biopsy signatures that might help us decide which treatment might be more appropriate. In my own practice, I do like to have a biopsy prior to starting therapy for IgA nephropathy, and I do actually try to assess, not necessarily with the MES score. The MES score is very much black or white, 1 or 2 or 0. But I try to assess the amount of damage. I try to assess the amount of inflammation, and that will sort of help me decide in my own personal practice what I might start with and how I might evolve the therapy. But again, just to be very clear, the data for that are not present right now. In terms of a repeat biopsy, I think if things are not going well, it's certainly reasonable to repeat a biopsy. If the patient represents after a number of years, I just saw a patient in clinic who really I'd seen years and years ago, and now they're back, and the proteinuria is worse, and the GFR is down a little bit. I asked to repeat a biopsy to see exactly what's going on, because if it's mostly scar, I'm not entirely sure I want to pound the patient with immunosuppression. So I think that's useful. In terms of what Sayna said, after you treat, we don't know what we're looking for. And my experience with lupus is that when you treat patients well with lupus and you repeat the biopsy, the immunofluorescence often stays positive for months and months and months, even years. And so can we clear IgA from the glomerular mesangium? I believe we can. My expectation, frankly, would be if we use drugs that actually interrupt hit 1, 2, or 3, or all of them together, that eventually we would clear from the mesangium. On the other hand, if we're using drugs that are acting primarily on hit 4, sort of preventing the damage from these complexes, they may still stay around. So I think it's a really good point. What are your expectations from the biopsy? And until we start seeing some of the data from these smaller rebiopsy studies, and they are going on with some of the newly approved drugs, that's a really difficult question to answer, but it's certainly not unreasonable.
Thank you. Yes, and I think one of the other important things that Sayna, you presented are some of the medications that are not approved or have no data to support use. And with all the new medications, not only supportive but direct therapy for the group to know when we're choosing. Pill burden is obviously important to the patients, and so making sure we're using things that have some evidence for them. We're gonna let Dr. Rubin, he's had his hand up, ask a question or make a comment. Go ahead, Dr. Rubin.
Thank you very much. Sayna, Brad, outstanding presentation. Thank you for your work.
Thank you.
I think the first question is the immune response is governed by the so-called immune response genes. What do we know about the role of genetics in IgA? In other words, are there certain genetic markers that will indicate to us a worse prognosis? Number two, the other rule of immunology is something that resembles the Argentinian tango. It takes two to tango, meaning the B cells do not work independently of the T cells. What kind of work has been done to look at the role of T cells in this disease? And thank you.
I'll take a shot. All right. I think the genetics, Columbia is doing a lot of the genetics of IgA nephropathy. I think some of the genetic predisposers that suggest trouble are, complement related proteins, regulatory agents, complement regulatory agents that might be present or actually absent can affect the prognosis. I think, Mario, your question is really a deeper question, which is, if because all of us have galactose deficient IgA, we all make it and we can measure it. And I've had my own measured when I was doing a project looking at galactose deficient IgA, and I have plenty of it, but I don't have IgA nephropathy. So why are some people making an immune response to the galactose deficient IgA? I think that begs several questions. One is, well, can you have galactose deficient IgA that's not pathogenic? I would suggest we can. Galactose deficient IgA isn't one thing, it's a spectrum of things, and we don't know what the pathogenic entity is. The second question is, to me, and I realize I'm not really answering your question, I'm asking more questions, but the second question is, when you have this deposited in the kidney, what kicks off the response? And the mesangial cells are really quite good at clearing things, including immunoglobulins and immune complexes. Maybe certain people's mesangial cells are genetically predisposed to not clearing very well, allowing too much of an accumulation, etc. So I think that's a lot of food for thought. I think genetics is sort of in an early era at this point in terms of IgA nephropathy. In terms of the T cell, we don't have a lot of data on the T cells. I guess if you look at the data from China with mycophenolate, mycophenolate affects T cells and B cells. Mycophenolate especially works on Th1 subsets. And so, you could say that at least in that population, there's some evidence that it might be relevant. Certainly, getting more earlier in the pathogenesis, what's creating the abundance of these B cells, forming too much galactose deficient IgA, if that's really the case, and you look in the Peyer's patches or the other parts of the respiratory or other mucosal surfaces, that was a question in the chat. All the mucosal surfaces can make IgA and presumably galactose deficient IgA. Maybe T cell helps drive that. And so those are not unreasonable questions, but I don't think that's been pursued very much to date.
Thank you. Going back to some of the monitoring, because that's come up a couple of times in your clinical practice, how often are you monitoring for proteinuria to look for relapse? Because there was a question to Dr. Norouzi too about what are your expectations on potential relapse in that patient once they're off of the Nefecon. As we've seen in a lot of the trials, some of the IgA, galactose deficient IgA come back. So, along with the retreatment again, targeting the immune response, and how often are you monitoring to look for this from a laboratory standpoint?
That's a really good question. We do have some data about flares after Nefecon so far, and that was the foundation of designing this extension study for Nefecon. For this patient, I'm actually checking his urine protein to creatinine ratio in his labs for eGFR. Obviously, I'm checking him every 2 to 3 months at this point, but I can add that phenotypes of the patients are so different. In some of my patients, they've had multiple flares in the past, and I don't know that if those patients are going to be at higher risk once you taper down Nefecon or you stop their medications for developing flares faster or more often because of the history of flares, multiple flares in the past, because their phenotype is just different. They have maybe more aggressive form of IgA nephropathy. These are the things that we don't have enough data about it, and that's the reason that we see practice variation. And I see it in my own clinic as patients sometimes are behaving differently. This patient had been stable since I tapered down Nefecon, but it doesn't mean that he's not going to flare up at some point. He'd had 2 flares in the past, so that's his history. And that's the reason that I'm following him up every 2 to 3 months.
I absolutely agree. Generally speaking, I follow the patients quarterly, so every 3 months, unless they're really, really high risk. And high risk might be the history, as you just mentioned. Do they flare a lot? Because past performance, I know in stocks doesn't prove future performance, but certainly it makes us worried. The other thing that you can think about, which I really enjoy doing, is giving my patients dipsticks, showing them where their proteinuria is and if something changes to call. And they can do that once a week at home. It's very inexpensive. It's a little bit more tricky with IgA nephropathy because it's different than minimal change disease where we expect the proteinuria to go away. But still, if they say, well, I went from light green to dark green, you might say, uh-oh, something's going on. So I think that's something that you can think about doing.
Yeah, I think that's an excellent point, Dr. Rovin. I always say, I think some of the misconception of patients is they have to come to clinic to see us before we can do anything. And so much of nephrology can be done based on a potential laboratory test that they don't need to come, as simple as that. So if they notice a change, we follow them closer. Very different than, I don't have the answer to the question on pediatrics and the data on pediatrics. And I don't know if anyone from the company does, as we're all adult nephrologists, the three of us here. But the pediatric patients are treated much differently, like you said, because of the minimal change and dipstick. So it's something we could potentially employ in our adult practice as well.
Could I, Dia?
Go ahead. Yes.
I just wanted to say one thing. Somebody asked a question, and I'm just going to summarize it because there are tons of questions here that are all really good in the chat. But somebody asked, does sparsentan or atrasentan only work on the, sort of the hemodynamics / decreased proteinuria, that type of thing, hit 4? And one of the things you have to think about for all these drugs and the way we think about them in KDIGO as well is that all these drugs have a primary effect and then lots of other effects. And there are data, at least in abstract form, from the ASN looking at sparsentan, for example, decreasing some pro-inflammatory molecules like CD163 in the urine. And we know from very old data that RAS inhibitors can also be anti-inflammatory and can modulate the immune system. So to pick out and say one drug does only one thing and absolutely nothing else is probably not the right way to think about it. I think drugs have primary effects and they have some necessarily beneficial other effects. And then, of course, they have not so beneficial side effects. So I wanted to make that clear. I think the endothelin antagonists or the dual antagonists can do other things, but we're giving it for a sort of singular purpose, but it can benefit other things. So keep that in mind when you're using the drugs, and there'll be more data on that forthcoming.
Thank you. And I think that goes along to one of the questions that just came in about, is it reasonable to use a combination of some of these with multi-targeted approach, although not studied that way, but is that something for the future potentially?
Well, I think Sayna and I've talked about this at our various meetings, and we've talked about it quite a bit. And that was sort of one of the points. If we believe we need to achieve specific goals of therapy in terms of proteinuria and GFR to really preserve kidney function for these often young people for a lifetime, it looks like none of the drugs by themselves are going to hit that. All of the drugs look like they provide benefit, but it's really reasonable to look, I think, and again, no data. I want to emphasize this. There's no data, but there will be in the future drugs with different mechanisms of action that attack the various parts of the pathway of IgA nephropathy. Combining them might actually result in synergy. It's a great idea. It certainly has to be proven, but why not? We combine all sorts of drugs for that very reason, for transplant, for lupus, for other diseases that we take care of. And so why not IgA nephropathy as well? So I think you're going to see a lot of these things blossom over time. I know there's been data looking at the endothelin antagonists plus SGLT2 inhibitors, right? And so other people might be asking, what about an immunologic drug or a primarily immunologic drug plus, an endothelin antagonist? Why not? And I think even Sayna, you said that you were thinking maybe you could add an endothelin antagonist on top of what you're already doing.
Yes, I totally agree.
Dr. Randhawa has had his hand up, and so let him make a comment and ask a question. Go ahead. Oh, you're muted.
Yes, thank you,
There you
Dr.
go.
Robin. That was a very enjoyable discussion. My question for you is, does the presence of a E1 versus E0 lesion in the MES score determine what you will, give? For example, would an endothelin receptor antagonist be better in those patients?
Well, I'm going to be very biased here. I am a slave to the biopsy. I really like to look at the biopsy and decide what to do. I think even though the data has not suggested that the E1 lesion is really relevant, I think that one of the problems with the MES score is that an E1 lesion can be atuft with some hypercellularity, or it can be a bunch of tufts with a lot of hypercellularity. And so again, I will I look at the MES score, of course, but then I go and I look at the biopsy, and if there's a lot of inflammation, and I'm defining inflammation by E-type lesions, crescent-type lesions, and then of course Ian Roberts suggests that some of the S lesions can actually be indicators of inflammatory activity, which is really interesting. That will make me do something different. And I'm not sure that makes me do an endothelin antagonist, but it would make me much more prone to do an anti-inflammatory early on to control the inflammation, and then folding in something to control the IgA, better. One of the newer approved drugs. So I like Sayna, I do not use a lot of systemic steroids anymore. But if there's a lot of inflammation, I'll use a short course of systemic steroids. And now, of course, iptacopan is approved. And so to me, you know, I love complement inhibition because I think it's anti-inflammatory. And I realize that the iptacopan study, whether E lesions were present or not, it didn't matter. But the reality was, even in that study, those biopsies weren't coincident with the treatment. So what I'm hoping is, and I think many of us, including our nephropathologists, are hoping, is that pathology studies in the future will be much more amenable to be used to guide our therapies. And many of us are involved in these repeat biopsy studies now to try and get some of those data, because I think that's a key question. If we're going to do a biopsy on a patient, we should use the biopsy to help us guide therapy if at all possible.
Thank you.
Thank you. And then our last question, and Dr. Norouzi mentioned looking at urine microscopy for dysmorphic RBCs, and it's come up a couple of times in the chat already. The value of hematuria in practice, and then will that be something that may be considered to be added to the guidelines? And I think, again, goes along with the lesions we were just talking about on biopsy. So where do we see that fitting in the future?
Of course, I knew that we're gonna answer a question about hematuria today. So I actually value hematuria in practice, and I do urine microscopy whenever it's possible, and I actually look at the hematuria history and see if the patient has had hematuria recently or not. There is a paper on JSON that Dr. Fervenza is one of the authors, and I actually posted that on the chat as well, that there are some data about the patient that they have persistent macroscopic hematuria, you're going to see some decline in their eGFR. And it could serve as a potential biomarker for us. And usually you see this decline in the eGFR based on the previous data is when you see hematuria and proteinuria at the same time. But isolated hematuria had been linked to decline in the eGFR over time as well. Although the decline that you see in the eGFR, isolated microscopic hematuria is much slower when you see that with a combination of proteinuria and hematuria. So I think that it could actually, it's one piece of information that I use in clinic when I'm deciding about the treatment when I'm thinking about like if the persistent hematuria is there and patient still has some proteinuria, in my opinion, probably IgA nephropathy is active. Again, a lot of things that we are discussing at this point for IgA nephropathy is that we need more data. And we just talked about the biopsy findings, etc. So these are the things that we really need to have more data on low eGFR, on pregnant patients. These are the really important questions that come up in practice because your patients are going to get pregnant. Your patients are going to decline the eGFR and they do not want to give up on their treatment because the situation has changed. And it's that we need more data at this point, and it's basically expert opinion as we are talking about in how we're interpreting the data, same as hematuria. I saw a question about if hematuria is going to be included in KDIGO next time, and that's a question for Dr. Rovin.
So let me say what I do, because I also follow hematuria as well. And I like to look at the patient's urine when they come to clinic, and I like to see the hematuria. And when I'm talking about hematuria, Sayna, I'm talking about acanthocytes. That's what I'm looking for. So I'm looking for glomerular bleeding. I like to see that resolve. And if it resolves and comes back, I get very worried about it, even if the proteinuria hasn't caught up. I think I'm going to be politically sort of neutral here. I know the guidelines have not included it, lack of evidence, but I do think it's another piece of the puzzle when you're evaluating an individual patient, and I think that's really relevant for an individual patient. I think what you just said was really an important concept, which is what is active disease in IgA nephropathy, because it isn't like anti-GBM where there's an explosion of inflammatory lesions, right? It's a much more subtle disease. And it does actually concern me. And I'm working on a case report with one of my colleagues where the patient had no proteinuria, only acanthocytes, and the patient's wife insisted that he get a biopsy. He did, and he had crescentic IgA nephropathy. So, I think what we're saying is it's really difficult to tell simply clinically what's going on, and you can certainly not say hematuria is meaningless. What I also agree with what you said. We need more data, prospective data, to show what the hematuria means and how that affects things going forward. And I'll push this question even further. I'm not going to answer it, but if you had a patient with IgA nephropathy and only microscopic hematuria, what do? Right? So do you watch? Do you treat? Do you do a biopsy and say, well, this is a pretty active looking biopsy, I'm going to treat? So I think there's all these questions that remain to be seen or remain to be answered. So I would say that IgA field has exploded, and with the explosion of new drugs, we have more questions than we've ever had before to answer about IgA, so we understand how to manage the patients appropriately. So how's
Thank
that
you.
for not answering the KDIGO question?
Thank you very much. I think we're going to end there. And this was excellent discussion. We could go on all day or night. I think talking about this, as you said, there are more and more questions as we have more and more therapies. And I think one of the things this group has done a great job of, and we need to continue, is collecting data on our patients as we treat them, collecting data on what we're doing with urine and seeing, and hopefully that will help guide us because that's so important. So thank you guys all for joining. Thank you to our sponsor for sponsoring this talk today, and for Brad and Sayna for sharing part of your day with us and educating us.
All right. Thanks so much for having me.
Thanks, everyone.
Thank you very
Bye.